Hi, everyone. We're going to get started with the next session here. So maybe if you could just get the door closed. Yeah, thanks, Darcy. Okay. Okay, thanks. Okay, great. We have a great session here starting now, and this is going to be some interesting case discussions, unusual cases, both with transthyretin amyloidosis as well as light chain amyloidosis. We've got a great panel here who I'll introduce right now. We have right beside me Dr. Francois Tourneau, cardiologist at McGill and CHUM as well in Montreal, and a close friend. We have Juan Idiquez, who is a neurologist here in Toronto at the University Health Network with an interest in amyloidosis as well. And then, I'm not sure if he's joined us yet, but we have Dr. Zaim Siddiqui, who is a neurologist at the University of Alberta in Edmonton. There's Dr. Siddiqui. Welcome. Thanks for joining us so much. And Dr. Siddiqui had to change his plans at the last minute, but we're really grateful that you're joining us virtually. And so, yeah, why don't we get started with the cases. I'm not sure the order that we have them. Perhaps you could load them up. And is it up to us? I mean, I'd like to decide. I'd like to start with maybe Dr. Siddiqui first, if that's doable. Just because he's joined. Oh, okay, yeah, we have Dr. Siddiqui's slides. So, Dr. Siddiqui, we see your slides here. So, why don't we start off with you and take it away.
Good morning, Noel. Just quickly clarifying, can you hear me?
Yep, we can hear you well, thank you.
And I am running the slides from my laptop, is that right?
Yeah, if you can put it in presentation mode, but we can see your slides.
Sure, okay,
Yeah.
Good. Yes. Okay, so and also thank you so much for inviting me. I'm Zaim Siddiqui. I'm a professor of neurology at the University of Alberta. The case I'm going to present today, it's a simple case, but does show the variability the disease presents with, particularly in our arena. It's a diagnostic challenge for us, and my presentation will go over some of these challenges. I have no disclosures for this presentation. So this is a 42-year-old gentleman who I've seen for about 7 to 8 years now. He had initially presented to me with numbness and affecting the left hand. When I took a more detailed history, it showed, he mentioned that he had some erectile dysfunction, but otherwise no other major symptoms. He had healthy immediate family members in that he had a biologic son and a brother. He mentioned that his mother in Portugal had a peripheral neuropathy and suffered from renal failure and also hemodialysis. Routine testing, nerve conduction studies showed that he had a classical ulnar neuropathy around the elbow. Nothing significant. If you look at these numbers, I won't go in detail. I know there's a major cardiology audience over here. But he had bilateral involvement of ulnar nerves. They reduced amplitude of ulnar nerves motor responses and also reduced amplitude of sensory responses. So a typical ulnar neuropathy around the elbows probably. He didn't suffer from peripheral neuropathy per se. He had normal sensory responses in the lower limbs and motor responses. Because of his autonomic symptoms, we performed autonomic testing. This is the Mayo protocol. We have an autonomic lab in our university, so I run that lab. And he had, just to show you, he had significant reduction of sweat responses in the lower limbs, legs and feet, but they were preserved in the upper limbs. Cardiovagal testing, looking at the heart rate variability with deep breathing and Valsalva. that showed that it was markedly depressed. Not only that, his blood pressure responses to the alfalfa, this lower right side, they were quite abnormal. And finally, the tilt table test showed he had subtle orthostasis, nothing rip-roaring. And here's the summary of his test. He had reduced sweat responses distally in the lower limbs. He had abnormal cardiovagal responses. There was not much orthostasis. You can see the blood pressure drop is not significant. To looking at the small nerve fibers, we do perform the quantitative sensory testing. And that showed that he had marked abnormality of perception of superficial sensations, cooling and heat pain as compared to vibration were preserved. So in summary, what this gentleman had was bilateral ulnar neuropathies. He had an autonomic neuropathy and of course small fiber neuropathy of quantitative sensory testing. Not major large fiber involvement. So based on his history, we did his testing and found that he had a classical VAL30 mutation, a TTR mutation. He also, testing showed abnormal urinary profile, and he underwent a renal biopsy, showed deposition of amyloid there. There was no cardiac involvement per se. Based on his symptoms and involvement of his multiple organs, nerves and kidneys, we started him on patisiran, and he had done well over the last 7 years. We regularly follow him up with nerve conduction, physical examination, nerve conduction studies, as well as autonomic testing, and overall he remains stable. So the case shows you that all patients who have neuropathic involvement in amyloid do not have the classical rip-roaring peripheral neuropathy. They have can be predominant autonomic involvement, some small fiber involvement. And so that leads me to the challenges of diagnosis of this condition. As I mentioned, because of its heterogeneity and rarity, it is a challenging diagnosis, and most patients underwent lot of testing, see multiple physicians before their diagnosis. This European study shows that of the 150 patients diagnosed with TTR amyloidosis over a 15-year period, about 1/3 were misdiagnosed. And this is not unusual. There are a number of diagnoses which are considered in these patients. These can be CIDP, most commonly confused with that, anti-MAG neuropathy, radiculopathies, paraproteinemic neuropathy I mentioned, and other acquired neuropathies. So it's very common for these patients to be considered for those diseases. Many undergo treatments, immune therapies, and in this study, about 1/5 underwent spine surgery before they finally diagnosed with ATTR peripheral neuropathy. What are the underlying issues that cause such misdiagnosis? One is its rarity. Its prevalence widely varies. It's much rare in North America as compared to some of the European areas. And most importantly, there is a very vast variability in its presentation, both phenotypic and genotypic variability. Even patients with similar mutations of the gene may present in a various manner. I'm talking about from the neurology perspective. Some may have one form of neuropathy. Even the neuropathy associated with amyloid is not classical. There are various. I showed you the case earlier on. He had predominant autonomic and small fiber involvement. Others may have a sensory neuropathy, and others may have routine sensory motor peripheral neuropathy. So because of this phenotypic variability and the rarity of the disease, it's hard to pinpoint, and patients have undergo a number of tests before the diagnosis is made. One of the misconceptions of this disease is it's a disease of young, which is not correct. Quite a number of patients present in older age. We'll go over that in a second. And many don't have established family history. And of course, as I mentioned to you, they do not have classical presentation. So the misconception that it's disease of a young people with established family history and classical presentation causes a number of times this misdiagnosis. Features that patients have that are misdiagnosed, particularly when it's late onset in older males, and we do have family history, and particularly if they don't have cardiac involvement, symptomatic cardiac involvement. These patients are liable to be misdiagnosed in many cases. Many of these patients undergo CSF tests, may show elevated proteins, which are seen in other neuropathies as well. And so again, that leads to misdiagnosis with CIDP and other paraprotein neuropathies. Nerve conduction studies may show features of demyelination, and one of the common misdiagnoses I mentioned is CIDP. And early on, these patients, the typical presentation is axonal neuropathy in these patients because of deposition of amyloid. But in many cases, it may have some demyelinating features, which may confuse the diagnosis. And I mentioned already the common misdiagnoses, CIDP, paraprotein neuropathies, and the list is on and on. And those are much more common with this condition, and hence many patients are diagnosed with those conditions. So diagnosis requires a very careful history, particularly looking for some red signs and symptoms, and we'll go over that. Those are the red flag signs, and then doing appropriate testing. The classical presentation, if it's there, in patients who have got a predominantly neuropathic variant, is a sensory neuropathy, predominantly sensory symptoms. That can be positive symptoms like burning and pain, or negative symptoms, numbness, associated with autonomic dysfunction. And it may be gut with diarrhea and constipation. I mentioned my patient had erectile dysfunction. Others may have orthostatic hypotension, but that's not the most common one. Orthostatic lightheadedness is a later manifestation. It's most commonly gut and erectile dysfunction. Some may have involvement of kidneys early on, or eyes, corneal opacities, or then rarely these may have arrhythmias, cardiac arrhythmias. Cardiac deposition in particularly in younger patients is much rare. In older patients, you get much more cardiac deposition. I'm going to skip this slide in the interest of time. So these are the main presentations phenotypically of amyloid ATTR. With the classical mutation, VAL30 mutation, presenting earlier on, they have positive neuropathic symptoms, sensory symptoms, autonomic symptoms, but not much cardiomyopathy. But with late, they may have cardiac conduction disturbances requiring a pacemaker, but cardiomyopathy in younger patient is unusual. Those who present late with VAL30 mutation do have neuropathic symptoms with, of course, significant cardiac involvement. In atypical presentations, non-VAL30 mutation, which is more common in North America, you have got a predominantly pure cardiac phenotype with conduction disturbance and cardiomyopathy, and then there's a mixed phenotype where they have classical neuropathy. This neuropathy presents with sensory motor features and of course carpal tunnel syndrome, mild dysautonomia, and of course cardiac involvement. So this is a correlation of genotypic and phenotypic categories in ATTR. So in early onset neuropathies, you typically find family history. They may have history of autonomic dysfunction. I mentioned vitreous opacities, kidney involvement. While in late onset, less than 50% have family history. And they have a progressive idiopathic polyneuropathy with early motor involvement, like walking difficulties. A patient who presents with older age with a peripheral neuropathy and early motor involvement and some autonomic features, this diagnosis needs to be considered. Here are some red flag symptoms which have to be carefully looked at in these patients. Patient presenting with progressive neuropathy with having one red flag sign or symptoms. And here's a list. I'm going to quickly run down this list. A peripheral neuropathy with carpal tunnel is common, but then if you've got systemic symptoms, autonomic dysfunction, it can be reproductive or it can be orthostatic intolerance, diarrhea, constipation, history of cardiac disease, particularly edema, and then family history is one of these things. If present the history, and if they have signs of systemic involvement, including heart, kidneys, or eye, this should raise a red flag. So, critical in the history in patient presenting with a progressive neuropathy to look for these systemic signs. As there is no neuropathy is classical. None of the patterns, a neuropathic pattern is classical. Sensory, sensory-motor, autonomic, small fiber, large fiber, it can present as any of those. Nerve conduction studies are important in all these patients. They do delineate the type of fiber involved, large fibers. Unfortunately, small fiber testing is not available widely. We have an autonomic lab, we can do that. Some labs do sympathetic skin response, which is a poor man's test for small fiber neuropathy. But a pure small fiber neuropathy in a young patient is a big red flag. And then, of course, autonomic testing is critical in these patients to look at the different type of fibers involved. Once you have red flag symptoms and signs, how to confirm the diagnosis? I want to show you the slide because many of these patients undergo nerve biopsies, and the sensitivity of nerve biopsies is not 100%. In fact, some study has shown it to be about 60 to 70%. This study mentioned about close to 80%. A negative sural nerve biopsy does not rule out the diagnosis. So that's the take-home message from this. Genetic testing is critical, and showing just abnormal mutation TTR gene is not enough. You have to show that in addition to the gene abnormality, there is amyloid deposition in an affected organ, maybe heart, maybe kidney, or nerve. So a combination of those two, in my patient which I presented, had the mutation, of course, but also had deposition of amyloid in the kidneys. So finally, the last slide, this is my last slide. Peripheral neuropathy with ATTR is a challenging diagnosis. It's heterogeneous with no classical manifestation or presentation. You got to history, show red flag symptoms and signs, and if that's there, you need to do appropriate tests. A negative biopsy does not rule out its diagnosis. And of course, the TTR gene sequences have very high sensitivity, and we, although it's not available across the country, but in major centers we have access to it, and in appropriate cases, it has got a very high sensitivity to diagnose the condition. It at least leads to the path of diagnosis, and then we do further workup, looking at their heart, kidneys, eyes. All my patients who have got these red flag signs and a mutation undergo a very detailed evaluation across various specialties. So I'm going to stop here, and thank you so much for inviting me.
Okay. Great. Well, thanks very much, Dr. Siddiqui, for that really interesting case and that fantastic summary. It was kind of interesting that the renal biopsy was positive in that patient. You know, we often don't think of the kidneys as kind of one of the main targets of ATTR, but certainly you can get deposition there. And interesting that there was ulnar neuropathy. You know, we did a little study of our cohort in Calgary and found that actually a quarter of our wild-type patients had ulnar neuropathy, which kind of makes sense, you know, if you think about the mechanism of soft tissue deposition and compression.
Yeah, and interestingly, this patient still does not have cardiac involvement. I've been following him for the last about 7 years now, and he's been on the treatment, and he has some progression of his neuropathy, but we get him cardiac testing every year to 2 years, and the heart is not involved still.
Oh, it's a fascinating case. You know, what I think we'll do for this session is maybe we'll have 1 or 2 questions after each case just while it's fresh, and then if there's time, we can have some more of a discussion at the end. So maybe we have time for 1 question for Dr. Siddiqui from the audience? Yeah. Patrick, you have a question? Do we have the microphone? Yeah, great. Okay, good. I don't have to remember it all.
Thank you, Dr. Siddiqui. My question is about ocular disturbances that you highlighted, and I was curious about, do you partner with an ophthalmologist to potentially monitor any issues related to reduced levels of vitamin A that may be coming from a repercussion of use of silencers in the PN patients?
So we do. I've got an ophthalmologist, and I go to ophthalmologist, and we do check vitamin A levels periodically. That's left to us, not the ophthalmologist. We do check the vitamin A levels at our end, but yes, we do have an ophthalmologist and a cardiologist at our center. We closely partner with.
Thank you.
Thanks.
Yeah, great question. And you know, we've had just our patients following with their optometrist as opposed to an ophthalmologist. And generally, we found kind of good monitoring with that. We haven't really identified an ophthalmologist in our center. We've had a few kind of retinal issues over the years. But yeah, no, that's an interesting question. So, okay, why don't we, thanks again, Dr. Siddiqui.
Thank you.
That was great. I really appreciate you taking the time to join us despite your travel schedule. We'll move on now. Why don't we kind of change streams and go over to the cardiac side and then kind of come back to the neuropathy side. And these are Dr. Tourneau's slides. So yeah, here's the tool to advance the slides and look
Maybe I
forward
will
to your
stand
case.
here because.
Yeah, that sounds good.
Okay, so thank you very much for having me today. I'm going to talk about cases which are like a little bit unusual. Diagnosis is not that difficult, but it raises a lot of questions. So I have a few cases to show you. And we have this expression in French, you know, un train peut en cacher un autre, like be aware, another train may be coming. So. So I'm going to start with, in fact, two cases, because it's roughly the same story. Two patients with a new diagnosis of heart failure with reduced ejection fraction. The first one is Mr. L, 77 years old. He has absolutely no cardiac history. He comes to the ER for heart failure, and he has a de novo rapid flutter. And that was last summer. TTE, which is done at bedside in the emergency room, shows that the ejection fraction is 20%. He's admitted in cardiology. He is getting CAS. He has no coronary disease. And the other patient, it's slightly the same story. It's Mr. M, 68 years old, no cardiac history. It's the first admission for heart failure and a rapid atrial fibrillation. He has the first TE, which is done in the emergency room, shows an ejection fraction of 35–40%. He had been investigated for coronary disease in the past, but he has no significant atherosclerosis. Both of them got managed with an ablation of the flutter for the first patient. He's put under diuretics, GDMT, and got clinically rapidly better. And for the second patient, was AFib, got a TE, there was no clot, cardioversion, diuretics, GDMT, same thing, and got rapidly better, like in 1 or 2 days. The second patient is still in the emergency room when he got all of this. And this is, just keep that in mind. So, the consult team who saw both of these patients in the emergency room figured that, they felt it's probably a tachycardia-induced cardiomyopathy for both of them. They will recover with time, and GDMT will follow them at some point in the heart failure clinic and see how they go. For the first patient, he got a new transthoracic echo 3 months later, just before being seen in the heart failure clinic, and his EF was up to 45%. And then the doctor who read the echo said, oh, it looks like cardiac amyloidosis. The first echo, it has never been mentioned, but it was a bedside echo in the emergency room. Patient had low EF, was not doing well, rapid flutter. So he got the full assessment, PYP scan, which found a grade 2. There was no AL amyloidosis. And I saw the patient in the clinic, in the amyloidosis clinic a few weeks later. He was, he's Caucasian from Algeria. He has no family history. And, the only thing I found is a carpal tunnel surgery 10 years ago. The second patient, I saw him by mistake. Remember, he was still in the ER. And so I remember very well, it was Friday night. The fellow of the consult team, and I was on call on the Saturday, just make the transfer. I said, oh, okay, tell me the story. He said, we sign off on this patient. He's going home tonight. And you won't have to see him in the ER on Saturday morning. So fine. Saturday morning, I arrive, usual stuff. You have 3 pages of patients to see in the ER. And I see the name of this patient. I say, why is he still there? And the nurse say, well, your fellow yesterday said he will sign off. He forgot to sign. So we didn't discharge the patient. The patient is upset because he's on a stretcher for 3 days. He wants to go home. I say, okay. I'm going to see this patient. It's going to take me 5 minutes. I'm going to discharge him. In fact, it took me 90 minutes at the end. So I saw him, and I said, how things go? Well, he said, I hope you discharge me because I can't stay here anymore. I'm on this stretcher. I have so much back pain. And actually, I wanted to ask, is this whole cardiac thing going to challenge a potential surgery for my back? I said, what are you talking about? He said, look at me. And then he showed me his hand, like this. And then he said, I can't move my back. I have a severe spinal stenosis. And he had trigger fingers on both hands. He had a carpal tunnel surgery, both sides, 5 or 10 years ago. I asked him to show me his biceps. He had the Popeye signs. And, he was born in Quebec. He has no family history. His family come from Germany, but like 50 or 75 years ago. So I said, I think everything is related to the same disease. I look at the echo, and the echo, it was in rapid AFib. There was, the walls were a little bit thick, but not that much. I wouldn't have called it a necessary cardiac amyloidosis on this first echo when he was in rapid AFib. But anyway, I say, I'm going to schedule you for an assessment. So asked for the PYP scan, came back grade 3. He got no AL, so it was clearly TTR amyloidosis. And he got a new transthoracic echo 6 months later, and the EF was 50%. And for all our patients within our program, we ask them for genetic testing. Even if the second one doesn't have children, the first one has children, we perform a genetic testing in everyone. So I'm going to ask you to raise your hands. So do you think that one of them, or both of them, will test positive for genetic? And if you think that one of them will test positive, which one do you think it's going to be? So does someone think that none of these patients will test positive? Nobody? Okay.
Oh, I think both wild type.
Both wild type for Dr. Fine. Okay, another both wild type. That's it. Okay. Who thinks that the first patient, the 77 years old patient, will test positive? 3, 4, 6, 7. Okay. What about the second one? Slightly more. Okay. So the first one was positive. The second one was negative. And personally, when I asked for the test, I thought it would be the opposite also. The first one, is from Algeria, so I thought, it's not necessarily a group at risk, but in fact, when I asked him afterwards, he said, I'm from the south of Algeria. And I mean, my family comes from a place where there's a lot of migration coming from sub-Saharan Africa. So that's probably how the mix was done. And the second one, because he had all these signs, because I didn't mention he had, orthostatic hypertension, everything, by textbook. And his age was 68. I thought most likely he would turn back positive. So the reason why I wanted to show you these two cases is, first of all, because both patients show up with FREF. And we always say, most of our patients have preserved ejection fraction or mildly reduced ejection fraction. But we shouldn't forget that some of the patients show up with a reduced ejection fraction. Sometimes it's because the disease is very advanced. Sometimes it's just because there's an event that triggers the reduction in EF, and they will recover afterwards, like for these two patients, the rapid atrial fibrillation or rapid flutter. And also because, I talked with to the fellow for the second one. I said, did you look at anything else besides the heart? I said, no. He said, because I kept your patients. I was like, why? So I told him, you should have done a complete physical exam. You would have figured out that this guy was not a regular heart failure patient. So it's really important to remind our trainees who are in the very specific specialties that they have to think out of the box. Otherwise, they are going to miss this kind of patients. So maybe I will stop here if there's any question, and then before moving to the next case.
Yeah, that's great. Thanks. Yeah, so a lot of, there's so many great points to mine with those presentations. So thank you, Francois. Yeah, let's open it up to questions from the audience. The whole issue of atrial fibrillation and flutter and management of that is a whole area unto itself that we all kind of struggle with. But yeah, let's open it up. Patrick.
Sure. Thank you, Dr. Tournou. I was curious if you were communicating to a primary care audience, what cardinal signs, you have carpal tunnel here. Are there any other signs that would probably come across that you would want to flag, maybe other than CTS, to a primary care audience that could probably relay to your clinic a bit faster?
Yeah, so usually we try with the easy ones. So the carpal tunnel, the trigger finger, the biceps rupture with the Popeye sign. I always show them this because it's easy in your office to figure that out. It takes a few seconds. For patients with AL, I'll talk to them about a few other signs, but I'm not going to say it now because that's the second case. But roughly that's for the primary audience. For the community, that's the main sign. We tell them, if your patient had pacemaker, heart failure, carpal tunnel, Popeye sign, trigger fingers, think about it. You can, and sometimes we tell them, you can just give us a call. You don't need to send us a patient, and we can figure it out and ask them to refer the patients.
Great. Any other questions on those cases?
I have one question.
Oh, yeah,
I was actually wondering if you would do genetic testing, like if you get a patient that has, that tableau that kind of reminds or make you think of amyloid, would you do the genetic testing as one of the initial tests, or would you wait to confirm before performing the genetic testing, especially if he's coming from a region which is a little bit, where the prevalence is higher, like from
Yeah, so
hereditary
usually
perspective?
we wait to confirm the diagnosis before doing the genetic testing. The only case where I'm not waiting for confirmation, it's because, for example, we have a few patients who are like 90 to 95 years old. Okay, there's no question about, or the patient is in palliative care, and there is no concern about giving treatment for this patient. We don't think there will be any benefit, but there is a family, and we have a few patients we tested after the age of 90 who came back positive, and this is really, really important for the family because we have one case where the patient didn't get tested, and then the whole family was, very stressed. They were coming from Haiti, so they thought maybe there is a genetic mutation. So we had afterwards to test all the members who wanted to be tested. So usually what we do, we say to the patient, listen, it's most likely amyloidosis. We are not sure. There is no real treatment that's going to change your prognosis for now, but if you are interested, we can do the genetic testing for your family to know, and so that's when we do it.
Thank you.
Yeah, great question. Yeah, I think our oldest hereditary diagnosis or variant was 89.
Wow.
Yeah, so just goes to show, and we've had a few who we've rushed testing on who are in palliative care, which I think have turned out negative, but is as much as kind of a relief, I guess, for the family. Yep. Is important because once they know the diagnosis, they start looking it up and start worrying about it. So those are great questions. Okay, sure. Yeah, why don't we take one more? Yeah, go ahead. Yeah.
As Dr. Fine alluded to, kind of the management of atrial fib and flutter can be complicated in these patients. But knowing that you had initiated GBMT on these two patients with reduced ejection fraction, did your strategy for that change once the diagnosis of amyloidosis was made? I see their ejection fractions have both improved, but do you think that was dealing with the arrhythmia issue and what's going to happen with their GBMT in that picture?
Yeah, so that's a very good question. So in fact, the first patient got rapidly better. He was on GDMT. Even, he had a small dose of Entresto, beta blockers, MRA, Aldacton, and he got the whole. I think he even got SGLT2, and we just didn't change the dosing. We didn't increase, but I didn't reduce it. The second one, I had to dramatically reduce his beta blocker because he was not doing well with a high dose of beta blocker. And he just had, currently has mostly, he has a tiny dose of beta blocker. He has some furosemide and Aldacton. He doesn't have any ACE or Entresto on board.
Yeah, that's a great one. And I think the old dogma that, beta blockers and vasodilators, Entresto, ACE inhibitors, you cannot use them has been challenged. And we're seeing, in registries and other data that a lot of more patients than we thought are on those medications, but you still have to be careful, and it's very individualized. Some will tolerate it well, and some won't. So kind of makes it interesting. So, well, great questions. Why don't we move on? You have another case?
Yeah, I have two other cases.
Two other cases. Why don't we check our time here? I mean, we have time. Can we move on? As you're learning, when cardiologists get together, it's tough to get a word in edgewise, right? So
I am minority.
Yeah. Can we move on to Dr. Adikiez and then come back to your cases?
Absolutely.
We have lots of time. So, Quest, are we able to load up
Thanks.
Dr. Adikiez's case?
In the meantime, the slides are ready. I want to thank for all the organization to invite me. I'm going to present a second case focused on the neurology side, neuropathy associated with amyloidosis. And the case is going to be short to present, but many questions will be arise from that case that we want to share from our experience. I would be happy as you have comment how you deal with this question, and if you have questions to me as well.
No,
No, these
no,
are,
that's me.
Yeah. I know pretty well the case. I can share with you without the slide if it's needed. It's a 40 years old male with a clear family history from Portugal with positive TTR mutation. And he visited us as the history that he had. And for sure, we developed a whole history. And on detailed questions appear a history of problem with coldness, hands, heating feelings in hands and feet. And there is no history of carpal tunnel syndrome, and there is no cardiovascular symptoms. On the autonomic field, appear history of increase of frequency of urine frequency, especially during the night, and erectile dysfunction. He's a 40 years male. No major complaints as symptoms. His main question was he want to confirm his heritage and he want to have the genetic testing. For sure, as we are neuromuscular unit, we run under conduction testing that back negative. At the same time, we test the vibration threshold and early testing for small fiber neuropathy that we hit the cold and heat threshold that also back negative at that point. Finally, for sure, we sent the genetic testing and back positive for him. We explained the test result, and the next question that he made us obviously was therapy. And our answer was, at the moment we have genetic confirmed, but we don't have confirmed neuropathy there. But he said, I have symptoms as you detailed describe. I explained him that the neurologic examination was almost normal and the testing back normal as well. We developed a testing, extended testing for a small fiber neuropathy, including a morphologic one, including confocal microscopy and skin biopsies, and back negative as well. And the patient make again in the next follow-up the same question, and therapy when and which one. For sure, we said, so we have a picture what's going on today about this mutation, but we don't know the course of this disease. And we don't know what's going to happen in the future. And of course, we want to keep track, you and your family. That is my first question. How and which test we're going to use to a biomarker to decide the best therapy for him. Anyone has an idea which one is the best? Because we don't know really. Anyone has any comment? No?
Well,
Dr. Siddiqui, maybe can help me?
Yeah, I was waiting for. Can you hear me?
yes, we can hear you.
Yeah, great case. And this is exactly what we are talking about. That you may have the gene mutation. The onset of disease is quite variable. So this patient requires very close follow-up. And particularly if you look at the classical VAL30 mutation, they have definitely autonomic involvement early. So I would carefully look for his gut involvement or bedside autonomic assessments. There are rare involvement of kidney, as you saw in my patient, and getting screening cardiac examinations with a cardiologist like Noel, I would keep him in closed loop and follow this patient yearly or every 2 years, depending on how the patient goes. So I would not start treatment at this stage. I'll wait for early signs of organ damage, whether it may be nerve, whether it may be kidney or cardiac or eye. So yearly examinations would something I would be doing.
Yeah.
That's my suggestion.
Thank you so much. As we are working next to the cardiology team, we decide to refer the patient as a complete cardiovascular and cardiovascular autonomic testing that we are waiting the result. And we plan a 1-year follow-up, repeating all the standard neuromuscular testing, nerve conduction, and be open the patient and his family to start visiting our clinic and start tracking this family. Yeah.
I just want to make one comment over here. You don't need very extensive autonomic testing. You can do bedside testing. Bedside vitals, orthostatic vitals, sinus arrhythmia on ECG. If the patient starts losing heart rate variability, that's easy to do bedside. And those things can help to detect early dysautonomia. Thank you.
Yeah.
Yeah.
And particularly skin, if you got a EMG lab, skin sympathetic response, SSR is like, takes 3 minutes to do.
Yeah.
So you can do those bedside and monitor the patient.
Yeah, yeah. The SSR response was present, but delayed on response in the legs. Yeah, yeah.
Yeah, thanks so much. I mean, that's a fantastic case, and I think as as awareness and knowledge expands, we're finding more and more patients like this, right, in the early stages and with screening, and patients who have a mutation, but no indications for therapy, but still evidence of disease process. Very awkward, difficult conversation when trying to explain to them that you don't qualify for therapy yet. We have to wait till you get worse before we can initiate therapy. Very difficult, and we're hoping that studies like ACT Early, as we heard about from Dr. Gilmore, will kind of inform us about this process. But I think a lot of us there's no clear way forward with this patient as far as how often to monitor, and we know to monitor them, but still very much based on clinical judgment. So that's a fantastic case. Do we have any other questions or comments about this for Dr. Adiquez? Why don't you get the microphone here, actually? Yeah, thank you.
I guess this is more a technical question for either you or Dr. Siddiqui. The problem with sympathetic skin response is that we don't have really good normal values. So in my lab, I have been using only present or absent rather than delay or what's the amplitude. And I was wondering what you do and how we can benefit from what your experience is. Thank you.
Dr. Siddiqui, do you
Okay, thank you. Yeah, you're absolutely right. Sympathetic skin response is a poor man's autonomic testing, as they say. It's absent or present. So we don't look at the amplitude or latency, whether it's present or not. But in a particular patient, if over follow-up, the numbers are changing, and the previously present response becomes absent, that is significant. So it's good to follow patients over time to see the change in the response. That's my approach to this. Thank you.
Yeah. As a general concept, I consider SSR as a screening method, and compare with the same patient through the time is the best way. And the way, as you mentioned, to absent or present is a very simple way to describe the waveform. Yeah.
Yeah, but it's a great question because it kind of brings up a broader issue about disease assessment and tracking, especially with dysautonomia, right, which covers a huge range of symptoms and testing. And I think our field is really challenged by a lack of standardized assessment. So I think we have we know what we're doing on the cardiac side. I think we have a pretty good understanding of polyneuropathy, although still, there's still areas that need more research. But with dysautonomia in general, I feel is completely, at local discretion and done in many different ways. And it is an important disease manifestation that we really lack a standardized approach for assessment too. And we're all kind of doing different things, is my impression, just talking, with colleagues around the country and around the world. So I think as we gain knowledge about how the disease affects, the rest of the body, getting away from a cardiac-centric, point of view, we'll gain better understanding of how to do that. So Joaquin.
One of the things I just want to mention, Noel, is the RR variability. I'm taking this sponge into cardiology. I'm scared to do that, but I'm still going to do that. This is the earliest marker of autonomic involvement. In most conditions, the earliest manifestation of dysautonomia is reduction and loss of sinus arrhythmia or heart rate variability. And so that can be looked into. It's easy to do on an ECG over time, and that can be the earliest marker of autonomic involvement before you develop orthostatic hypotension and all others. Thank you.
Yeah, excellent point. Yeah, go ahead.
So in Europe, they use a neurofilament light chain as a easy way, to monitor patients. So mostly actually for hereditary patient, when there is a diagnostic in the family and the other one are genetically confirmed and asymptomatic. And actually they also use it somewhat to monitor treatment response. What is the status of that in Canada?
Yeah. We are not using that one as a clinical standard. And the thing that can change the serum level for this marker has been described for more than 20 or more neurological diseases, are being responded for many therapies in other trials, in other conditions, and we don't know really what truly changed this marker. Yeah,
the NFL story, I feel, is we're chapters into it, but we still haven't found kind of the consensus approach on how best to use it, or whether to use it at all, routinely. Great question. Maybe we'll do one more question, and then we'll move on to the next case from Dr. Tourneau, and then I think we'll have a few minutes for discussion at the end. So.
Yeah, I was curious about your thoughts for the future of wearable technology. We know iOS, Apple Watch has embedded a lot of nifty tracking features, and I'm curious how you think in the future that will evolve to help neuropathic involvement.
Yeah, it's a great question for sure. I've been really into the AI and wearable tracker for heart rate variability. Nowadays, we are wearable ways to well approach the blood pressure as well, especially with algorithm. But it's one way, the basic individual healthy marker, and bring this data to health science is a huge gap of knowledge, and they are not approved for clinical trial. It doesn't mean that we cannot go through that and push that increase the research, clinical research on it. At the same time, there is no one standard. There is something new, and year by year, more and more advanced technique appears. That means we are working on the clinical research, but the technological development is more than running or flying. That means we are maybe discussing something that they already be able to track. I open as the industry focus to develop wearable device focus on track disease more than use individual wearable devices to our field. That is my personal opinion for sure.
Yeah, yet another area where the technology is kind of racing ahead of our ability to understand it, although we've got lots of patients who come to us with lots of questions and lots of data to show us. So, okay, that was a great case and a great discussion. Maybe we can move back to Dr. Tourneau and load up his slides again. This is his first set of slides. So
no,
have to go
I think that's, no, that works. Right, yeah. So again, another train.
Another train.
So this one is a 72-year-old lady born in Haiti. She's a retired nurse. She's known for hypertension, dyslipidemia. She has MGUS. She's followed up by a hematologist. Last time she was seen was in 2023, spring 2023. And it was said to her she was perfectly stable, there was nothing to worry about, and she should be seen during the spring of 2024 again. She has a family history of a father with heart failure, which was not really clear why he had heart failure. He had diabetes, uncontrolled hypertension, he was in Haiti, so we don't really know exactly what happened at that time. She's admitted for heart failure herself in 2024 at the springtime. And it's in a community hospital, it's a bit North Montreal. Echo was performed, I think it was an internal medicine doctor who did the echo. Said, oh, it's preserved EF, but he thought that it was suggestive of amyloidosis. So I can tell, at least the work we do to raise awareness among the community works, because I'm not sure this patient would have been, diagnosed a few years ago. Patient was sent for a PYP scan, and his PYP scan conclusion was indeterminate, visual grade of 1. So patient got rapidly better with diuretics. She was discharged home with an appointment for a cardiac MRI. That's what the team over there decided. She got a cardiac MRI 3 months later. She was on the wait list. Still, findings concerning for cardiac amyloidosis, increased left ventricular wall thickness, and she had, again, some pleural effusion and a little bit of pulmonary edema. And she had a follow-up medical appointment with a community doctor in July. And then the doctor saw that and sent her to our program. And that's a referral we got. So 72, hospitalized in March, heart failure, echo suspicion of amyloid, PYP scan, indeterminate, cardiac MRI, suspicious amyloid, non-MGUS, followed by hematology. Priority routine. So she came in our clinic in October. Okay, and her question was, do I have hereditary ATTR amyloidosis? Because remember, she's a retired nurse. So she did her homework, she looked at the different websites. She said, okay, I'm from IT, I'm at risk. I have kids, what's going on with them? And so, we do the consultation. She's a little bit short of breath. She has no pulmonary congestion. She has a mild leg edema. That's her EKG and echo, the same day at the clinic. So she has a micro voltage. You can see she has a little bit of pericardial effusion, LVH, a little bit of RVH, big atria. Her troponin is 168. Her anti-proBNP is increased as well. Then I tell her, show me your finger. And this is not her fingers. I took a photo from another publication, but it looked even worse. At the beginning, she didn't want me to look at her fingers. She said, they are so ugly, I'm ashamed to show you my nails. Okay? But what you could see is this aspect of the nails that can be easily broken. They are a little bit thick. And I said to her, I don't think you should be worried about your kids or everything. I'm not sure it's ATTR amyloidosis. I said you should have a cardiac biopsy rapidly, and we should figure that out. And she said, there's no way I'm going to get a cardiac biopsy. My husband is very sick. He's currently hospitalized. This is not the right time for me. So what if I get a complication? So she didn't want to go for a cardiac biopsy. So I said, listen, let me try to organize quickly with our nurse practitioner a punch biopsy. We can do that in the clinic. We can do that. So Valérie, our nurse practitioner here, I sent the patient to her. She did the punch biopsy. So, with a very small punch, we take a small carrot of fat. It's like a fat pad, a mini fat pad. And we sent that for pathology. It came back positive for amyloidosis, which is already an interesting information because, patients with ATTR, we never got that positive. It's only with AL because you need to have some kind of a big load of amyloidosis in the tissue to find some, especially for a mini fat pad biopsy as we do. We sent the sample, I don't remember if it was to Toronto or my clinic, and it came back as AL amyloidosis on the mass spec. So, the patients got called back, put under chemotherapy. The hematologist was involved, and the patient got their treatment. Question is, could the diagnosis have been reached more quickly? And the question is because it took 8 months for these patients to have the right diagnosis. And we know, especially for AL amyloidosis, each month counts. So remember, she had an admission in March, MRI in June, son by the doctor in the community in July, so in the amyloidosis clinic in October, and finally got the final diagnosis in November. So initially, I think it's a series of data that pointed the team in the community in the wrong direction. The first thing is the PYP scan. The team wrote clinical information, 72-year-old female, suspect amyloidosis. And so the nucleus said, the cistic is indeterminate for the presence of TTR, amyloidosis, grade 1. But, it could have said, I cannot rule out AL as well. Because we know that, patients with AL, they can be grade 1. So then, the team thought, okay, so 72 patients from Haiti, the MGUS was stable, and I was not able to retrieve the blood test they did in the community hospital. But the change in the light chains was, there was some changes, but we cannot blame them. It was not very that different from what she had in the past. And they even sent a consult for a hematologist but we have this new diagnosis. She was supposed to see you, but she was admitted in the hospital. Can you see her again? And that's why they asked the MRI, which, at the end has no additional value for the diagnosis, just delayed the whole thing. And finally, the thing is that we need to raise also, we need to teach our community colleagues to look at other signs, especially for AL. So the nails I always feel it's a pretty good one. I mean, patients with advanced AL amyloidosis, most of the time, they have some nails which are not normal. And that would have changed probably the request they sent to us from a routine priority to a urgent priority. And then we would have seen the patient faster. And if we would have missed this step, we could have saved 6 months, probably. So that's why.
Yeah, that's a great case, Francois. Thanks very much. And kind of lots of kind of individualized features about looking back and seeing where it was missed. This is a scenario that's all too common still to our hematology colleagues who are in the audience. And I think it's always interesting to kind of look back and see where the opportunities were. But this is, particularly with the rise of ATTR and all the therapies and all of the push to kind of recognize earlier, this still gets forgotten, I think, too many times is subtyping appropriately. So we have a few minutes for questions or comments about this case.
Yeah, just curious, did they have macroglossia?
So she had a mild macroglossia, but it wasn't obvious. I mean, if you don't really look for it. It's not like the one with the typical macroglossia. She did not have raccoon eyes, neither, bruising. That was just the nails. But the funny thing is that when I asked her, show me your nails, and she didn't want me to. She feel like they are not nice. I cannot get them nice. I don't want to look at them.
Yeah. No, that's an important detail. So thanks for Dr. Sachawala.
Yes. So again, as Dr. Fine said, we do see this all the time, despite increasing awareness and increasing education of the community. I think there were several features that were probably not picked up, and I think, or maybe did throw a curveball because she was from Haiti, and there was some family history of heart failure. I think monoclonal gammopathy of unknown significance is also quite common in African Americans, in Black patients. And we reported, Rodney Falk's group reported that it can be coexistent as monoclonal gammopathy of unknown significance in patients with ATTR amyloidosis in anywhere from 20% to 40% of patients, and particularly in Black patients, it is more common. I think, what was the type of monoclonal gammopathy that was seen in this particular patient?
It's a good question. I don't remember.
Right. So if it is kappa, again, it is more common to have kappa monoclonal gammopathy of unknown significance, whereas AL amyloidosis, 80% of the cases are lambda. So if she had IgG lambda or light chain only monoclonal gammopathy, I think that would also raise suspicion that this could be something other than ATTR amyloidosis. As we are into this field even more, we are seeing more and more cases of dual amyloidosis in a single host. And the question comes up if this person should have had, if by chance she was V122I positive, that should she have had a heart biopsy to really make sure, is this really TTR in the heart or is this AL in the heart? She was not, genetic testing was negative, so unlikely, but really the abdominal fat pad versus the surrogate site biopsy versus the target site biopsy also does come up. We just reported it on our 7 or 8 patients with dual amyloidosis. So again, these things are happening, and with mass spectrometry, I think we are getting better at identifying accurately the amyloidogenic precursor protein, which obviously was not the case 10 years ago.
Yeah, great comments. And I mean, just my anecdotal experience talking with colleagues in the community, in the cardiology world, and probably in the neurology world possibly, is that the screening for light chain is a difficult and sometimes frustrating thing. And the number of times that they find light chain is low enough that it maybe still kind of drops down on the priority level, at least psychologically, as they're working up a patient. And the vigilance maybe is not there as much as it should be, but it can be a frustrating area with lots of nuances. And this is kind of a nice example of how it gets missed. Chris, did you have a comment?
Yeah.
Oh, Dr. Siddiqui, did you?
Yes, I just mentioned
go ahead,
something
and then
in my
we'll take a
presentation.
comment from Dr. Venner.
Late onset hereditary ATTR has got extreme male preponderance, extreme males. It's predominantly and extremely preponderant in males rather than females. And that's another one in this female patient, which makes it unlikely to be a hereditary ATTR. That's something else, just a red flag I just wanted to point out.
Yeah,
Thank
great
you.
comment. Thank you. Dr. Venner, maybe you can kind of take us into lunch with your comment. Yeah.
So I think this is where us as hematologists need to step up and help our neurology and cardiology colleagues to just be available to interpret those things unofficially or officially. But I think it is a huge step forward that our subspecialty colleagues are ordering the test, ordering the light chain tests and SPEPs. So that's, I don't want to ever discourage that, and I happily take the consults for the kappa light chain that's 26. To say it's probably nothing to worry about. The other point is that a big red herring here was stable MGUS. And that's a problem. We're a victim of our own success there. This patient was picked up and had an MGUS that was diligently followed by the hematologist. But you don't see the progression of the amyloid go hand in hand with a rise in the light chain necessarily. She had clearly a plasma cell dyscrasia that hadn't really changed, as you don't necessarily expect it, because she doesn't have outright myeloma that's proliferating. But there's still light chain, amyloidogenic light chain being produced probably for years, right? And so I think that it's, even in those quote-unquote stable cases, it's always important to revisit it. And that's actually one of the biggest reasons why we follow our MGUS patients. And one of the things that I always tell our fellows and residents is pay attention to all those other tests that you order when you're following the MGUS. Pay attention to the albuminuria that may be developing, to the cardiac symptoms, neuropathy, et cetera. Even if the light chains are stable, look for that dysproteinemia.
Yeah, great comments. And I think still a challenge, right, in the community, right, especially with all of this MGUS now being recognized, now that we're screening for it many more patients to monitor. And I think a challenging area to find the best approach to monitor. And if you have a friend who's a hematologist or you're in a center where you have really good access, that's great. But I think we still need to build up those resources in the community to better monitor these patients. So great comment. Well, I think we're at noon. Yeah, go ahead.
I just have one case left. So if you're not too hungry, and the reason that I want to present is because I don't have the answer. And I would like to have the general opinion.
We'll solve it for you, yeah.
So, So it's a story that I saw. This is the first case I saw, but we are starting to see more. And I think we might see more and more. I'm not sure exactly how we will have to manage them. So it's a 50-year-old man who is from France, but in fact his mother is from La Martinique, and his father is French Caucasian. Okay. And he's in Quebec, and he decided that he wanted to know who were his ancestry. And there's a lot of tests that you can order online. Actually, I checked on one of these websites. There was yesterday a 30% discount with the code of Halloween. And it's pretty cheap, like it's $100 or $150. And so he took the option of having a health report. And then he got his report, and as you see in red, it said increased risk for hereditary amyloidosis. So then you click on it, and it says that, bingo, you have one variant detected in the TTR gene. And I asked him, can you share the full report, because I want to know what exactly was that. And it's interesting, because the full report gives you a full description. I give you a few, like 5 pages, okay? But, it explains what are the different mutations, what are the typical signs and symptoms, and they tell him that you got the V122I. So, and then at the last page, he said, since you share your DNA with your family members, they may also be interested in this result. And your children has a 50% chance of having the disease, and your sibling, etc., and one of your parents is a carrier. So, when you get a bad news like this, he's doing what everyone does. You call your mom, okay? So he called his mother, and his mother said, wait a minute, your grandma has heart failure. She lives in France, in Strasbourg, and so the mother of the mother, of course, and she got a PYP scan in Strasbourg, and cardiac amyloidosis was confirmed. She was 87 at that time. And she got genetic testing positive. So now the mother knows she's a carrier. So, of course, patient was highly stressed because, first he had to share the news with his whole family for something he did himself. It was just to have info about his ancestry. He didn't have kids, but he wanted to have already some sign of the disease, so we performed a full assessment. Phenotype was completely negative. I think Geneviève even saw him also. But, the thing is, that was the first case. We have a second case, and I think there's even a third case I have at McGill. So we are seeing these patients, these people, taking some tests, getting some results. And as I said yesterday, I went to one of the websites of this company, and I clicked to see, what does they disclaim? There's nothing. I arrive in 3 clicks, being ready to put my credit cards. But there's always, the small lines at the bottom that you never read. So you click on this. And they say, okay, you might have bad news, we are not liable for anything, blah, 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 etc. But of course, nobody reads that stuff. So it might become more and more frequent. So the reason why I wanted to share the case is because, first of all, it's different situation from a patient with a relative from a cardiac amyloidosis patient and who actively wants to know if he's positive, if he has a gene. As this one was not really his question. He didn't understand. He didn't understand that. And so, what do we do afterwards? Of course, we have to, make sure these people stay, get reassured. We do the full test, but in a busy clinic like ours, it's a lot of resources. If we are getting more and more of these patients, this is an issue. And then, they're starting to have some guidelines on how often we should reassess this patient. But I just wanted to have global opinion if anyone else had some cases like this or not.
Yeah, well, I think, we're seeing more and more of these things, and I think we're starting to come together as a field to how to follow them, but we still have a lot of unanswered questions, and it's very individualized, right? The mutation, the phenotype, the genotype, the age, of the patient. This patient was 52, so I don't know if we have any answers for you. I think we have kind of a lot of, anecdotes and experiences, but I don't know if we have a consensus.
Can I make one comment?
Yeah, sure, absolutely.
The particular mutation you showed, that's the most common mutation in North America. About 40% of patients with amyloid have that mutation as compared to VAL30. So when somebody comes to you with a test like that and a mutation, particularly the history, I would probably, this is not the one which this one needs to be followed, this particular case, closely, because of the family history a little bit, plus the type of mutation that patient is showing. But I agree that there are more than 140 or 150 mutations now. How many? But this particular, interestingly, is the commonest one in North America. So I'll follow this patient closely, and particularly the cardiac and autonomic side of things, which are the more common ones.
So the mother of the patient doesn't have any symptoms. It's just the grandma who's finally developed heart failure at the age of 85 or 84. At the time when she was diagnosed, she was 87.
Yeah, well, there's a lot of questions here. Dr. Sajwala.
Genotype positive, phenotype negative, it's a common phenomena because of cascade testing of the families, because every time we have a patient proband, we always refer them to genetic counselor. In Massachusetts, where I come from, there is a law, state law, that nobody can do a genetic testing, quote unquote, in the hospital without having a pre-genetic testing counseling. So even for wild type TTR, when we are trying to rule out variant TTR, we have to have a genetic counselor. And then the whole family / cascade testing takes place. So we are seeing a lot of genopositive, and where I work is Boston Medical Center, which is an inner city hospital where there are a lot of black patients. So we do see a lot of V122I genopositivity phenotype negative. Early ACT trial that Julian Gilmore mentioned is a trial for genopositive phenotype negative patient, but it's a difficult trial to enroll currently because the predicted age of disease onset, there's a calculator that because this patient has genopositivity, but the first family member who developed the disease was not till 85. So he may not be even eligible for the trial because it is only 10 years before their predicted age of disease onset. So he may be eligible at the age of 70 or 65 or whatever it is. So again, these things are happening and they are being developed. But I think you are absolutely right that we've gathered a lot of patients. And how do we follow at Boston University Amyloidosis Center? So when we have genopositivity, somebody like him, I think we would see him back in 5 years. Yeah. Again, obviously sooner if they develop disease onset.
That's exactly what we plan. Actually, this patient is moving to Switzerland, so I sent him to a center in Geneva to be followed. I gave him a copy of his file. But the thing is that, when I train from France, and this commercial genetic testing, it's completely forbidden by law. And there are few countries in Europe where it's forbidden, not all of them. So, when he told me that and I got this result, I was like, how come and when he opened it, of course, the first thing he did, he Googled it. And then he was scared. Do I have a heart failure? I'm going to die, So it's, how we should take care of this patient, but more on a psychological part, because they didn't, I feel sometimes they didn't really freely consent for having this genetics testing.
That's a good point. Jean-Pierre, did you have a question? Or I don't want to neglect this side of the room.
Thank you. So Geneviève Matt, neurologist in Montreal. Yeah, so I guess it's more of speaking from experience. Yeah, so we see pre-symptomatic carriers, and we have to be careful as well. Sometimes the mutation predicts a certain phenotype. We know it might not be the whole truth. So, and I leave it up to the patient. Do you want a yearly follow-up? I can't see people more often than that if they're not sick. Or leave my number so that they call back once they have symptoms, but at least 10 years prior. But there are also lots of confounders in certain mutations, and it's really hard to convey to patients it's probably not your mutation doing this. Like, let's fix what's fixable, your diabetes, stop drinking, and we'll see it from there. But it's interesting, and actually there's another gentleman whose mother was finally tested for amyloidosis thanks to this. She was having cardiac issues on her own. A 60-year-old, otherwise healthy woman developing AFib for no good reason. And it's when her son did an ancestry and turned out positive that we were able to connect the dots. So.
Thank you. Maybe we'll just finish with Estelle, and then we can conclude if you have a comment. But no, when you start digging through the family closet, it's kind of amazing what you find, right? So.
I guess my question along the same line is, when you, I guess once you've seen those patients, and doctor, you said you see them every 5 years, but do you give them, for those that have family physicians, do you give them some maybe guidance for the family physicians to follow, like before you see them, so that they can maybe, I don't know, identify any early sign or whatever, something that you wouldn't see, and if they see that, they can quickly refer them back to you? Do you have those kind of,
Well, so far, the only patients I got are young, and they don't have a family doctor. So I didn't have this question. So but most of the time they because they come to us, they try to figure out a way to get a reference for genetic testing because, they don't have a family doctor. So they struggle a little bit at the beginning to figure out how to enter the healthcare system. And so usually they get a lot of information by themselves. So, we give them a copy, especially if they move around because of their job, and then they provide that to their own general practitioner. They probably teach their general practitioner about what they have. But I didn't have the case where, the patient had a family doctor and I have to give the information to the family doctor.
Yeah, I mean, it's a good question, and I think there's a lot of, regionality to how this type of monitoring is handled. My personal experience is that, to expect family doctors to really be following this closely and to know the nuances of these is really too much to ask. They're just overloaded with work already, and we see this too sometimes on the light chain side. Is that please follow the light chains and MGUS markers, and I think it's just too much for them to really, and it's not necessarily fair. Even so, our approach is to really try to educate the patient. Now we've got them, we've got their interest to bring this. If we lose follow-up with them, to kind of know these signs and symptoms and to bring it to their care providers as an issue, as opposed to saying, hey, family doctor with thousands of patients on your list, please follow for these subtle signs and symptoms of disease. But I think there's a lot of differences in how this is handled regionally. So it's a great question and comment. So that was a great case. Thank you for clearly a lot of interest in it. So I want to thank Dr. Siddiqui for joining us, Dr. Tourneau and Dr. Adikias for some great cases. You've stimulated our knowledge and our hunger for knowledge, and you've stimulated our appetite for lunch. Sorry, bad, terrible pun. Okay, with that we will conclude, and we will reconvene at 1:30. So enjoy your lunch, everyone. Thank you.
Great.